Good afternoon, sir. Good afternoon, everyone. So I'll be covering the part of UBM and iOCT in pediatric cataract. So to introduce, we all know that UBM is a contact procedure and it is a pre-operative imaging. It is not an intraoperative imaging. So it has low resolution and it wants to give much larger field of the anti-segment, and it provides the macro detail. Macro means it's going to give more about the corneal, antechamber and total lens dimensions. In contrast, if you compare with the iOCT, which is going to be a non-contact procedure, there is no touch of the eye, so it is going to be intraoperative. While you are operating or before operating, you want to see how the lens, which includes the anticapsule, intralenticular and the posterior capsular changes looks like. And it's going to be high resolution because it is going to cover a very small area. That's why it is going to have better resolution, and it provides the micro details. So to begin with UBM, it's a 35 megahertz which we are going to use routinely, and as most of the speakers have said that it's going to give parameters related to lens thickness, which is very important, and bag diameter, because once you want to put the IOL, we need to have a bag diameter dimension, then only you will decide how the IOL is going to behave in the bag, right? So if bag support is not there, then you want, or you are curious about the sulcus diameter, that will help in understanding how the multipiece is going to behave, and of course the antechamber depth for research purposes. So this is how we do UBM, and you can see that patient is lying under general anesthesia. So you are going to use this cup. So these are plastic and rubber cups, so which are available for different sizes. So kit could be small and kit could be large, or even it could be adult. So depending on that one, you are going to have 3 to 4 cup sizes of different dimensions. So you are going to use whichever fits for the eye, and you are going to retract both the lids, and you are going to keep around the limbus. Make sure that you are not going to rub or touch the cornea. You are not going to cause any corneal haze or epithelial defect. So once you put that one, you are going to slightly indent on the sclera so that it should not be leaky. After that, you are going to inject the saline, right? So you are going to fill it. You can fill more than 50% of the total cup height. So after that, you are going to take the probe and you are going to insert it into the liquid. After that, you are going to press it on the monitor just to say start the scan. So once you do that one, you can see that here you are able to see the lens details. So the more you move into the water, the scan will move up. So that's how it is going to say that don't touch the probe, and if you more move upwards, the scan moves down. So it should be in between so that it exactly fits, so that it gives the details from the epithelial surface till the anterior vitreous, because we want to see the PCD changes also in some cases. So here in traumatic case, you can see that you can see the iris configuration. On this side there is a gap between the posterior surface of the iris and the lens capsule. It means that probably volume has contracted, the lens volume. Here you can see that there is a PC breach. Because of that, when the iris is struck the anticapsule and the lens matter is herniating into the sulcus, right? So you need to lift up this iris and you need to do the rhexis. Probably you are not going to get any anticapsular support here. So that's how you got to know that there is an anticapsular breach and the lens matter has escaped into the sulcus. Of course, the posterior capsule is intact, but this is the vital information which you are going to get on UBM. And one more thing is, like when you are doing the scan, UBM scan, you need to put the cup here. So there will be a probe which is vibrating, right? So if this is a corneal diameter, you need to take it from the temporal to the nasal, so that you are going to get all the changes from nasal to temporal. Similarly, you need to rotate the probe and you need to come from the inferior to the superior side. So that's why you are going to cover the 360 degree of the eye while scanning. So I'm going to explain the practical application of UBM using some of the examples. So this is set 1. You can see that there is a white cataract. You don't know what is the capsular status, how the posterior segment is. So in these cases, rather than just like jumping into surgery, if you do UBM, here you can see that how to read a UBM. So this is a good UBM in both the cases, and this is right eye and this is left eye, the same patient. Here, as previously I said, you can see that there is a gap between the iris and the lens capsule. It means that lens volume has contracted. Either it could be a small lens, or it could be absorbed cataract in traumatic cases, or it could be congenital cataract where there is a PC deficiency. That's what you are able to see here. The anterior capsule is flat, otherwise it will be convex, but here it is flat because the volume has been lost through posterior capsular dehiscence. So you can see that the cortical matter is in the anterior vitreous and there is a breach in the posterior capsule. Similarly, in the other eye, you can see there is a much more absorbed cataract, and again there is a PC breach, and that's how there is a cortical matter in the anterior vitreous. So of course, by looking at this one, you are going to change your IOP parameters, whether you want to introduce the IA Pro first or the cutter first. everything changes based on the UBM finding. So this is second case where through different PCOs we want to see how the PC is exactly. So here you can see that this is a very flimsy PC which comes through IA probe only. So in other cases on the right side you can see that this is a fibrotic plaque sort of thing, anterocapsular phimosis sort of thing. So you want to see that whether this is fluffy. If it is fluffy, it can come through IA probe, bimanual aspiration, right? So otherwise here you probably need to give a nick through MVR, or you need to cut using intravitreal scissors, then do a rexus sort of thing using intravitreal forceps. So that's how it will help in differentiating what sort of opacity you have, and it also helps in assessing if you are putting the lens in the bag or the sulcus, is it tilting, is it like equally aligned on both the sides. That's how UBM is going to tell about the postcapsular opacification and also the lens status. So this is one more case with anterior subluxation of the lens because of spirophakia. You can see that the lens is touching the endothelium. These are for educational purpose. Of course, we will see on the slit lamp or during microscope, but that's how you are going to tell the findings to the naive surgeons or the young people who are like studying the cases, right? So this is one more case where you can see again there's a white cataract, but there's no PC deficiency, but the bag is so thick. So because of this one, you are going to have a very thin posterior capsule. So you'll be having a difficulty in doing PCC. That's how you are going to understand through the UBM. And here you can see that this is a zonular with riders. Again, the lens volume is normal, the anterocapsule and postcapsule looks clear, and you are not going to have any problem here. So the next comes the iOCT. iOCT is an intraoperative thing. So as I previously said, the UBM gives the macro details and it gives the micro details. So it's going to have a circle here. It has a vertical scan and the horizontal scan that can be moved on the microscope itself, and you can just move that one to the area of interest. One negative factor about iOCT is it's not going to give any details below the iris because it's a light dependent phenomena. It's going to image only through the clear axis. So if you do UBM, you'll be able to see some sort of plaque, but here if you do iOCT, you can define the plaque. Okay, there's a plaque here, and to what extent it is extending? Oh, it is extending from here to here. Can I cover the plaque within the rexus, or it's going to hamper my rexus, right? So it is in the center, you can do the rexus. And if you want to do rexus here, see, you can see it is not a normal capsule here. On the right side, you can see this capsule is normal. You can do a good rexus here, but probably you need to put more force here or you need to cut it here. So that's how you are going to decide the micro details on AIOCT, right? And this is the second details. That was anterocapsular changes on iOCT. These are micro details, and this is the intralenticular and the postcapsular changes. So here the surgeon is doing the hydrodissection. Of course, Professor Coker is the surgeon here. And once you do the hydrodissection, how the lens material is behaving. In some cases, some membranous cataract, the material won't dissect it out. So in those cases, probably you need to use phacoaspiration. So those are the indications which you can understand. Okay, here you are injecting the fluid into the lens matter, and you are able to see that the lens matter is sort of loose. So that's how you can take it out using bimanual aspiration. So on the right side, you can see that there's again PC deficiency. So you can see that both the leaflets of the capsule are falling into the anterior vitreous, and again, AIOCT helps in understanding, okay, the lens volume is very small. Once you do the rexus, hardly there will be any lens matter to aspirate. That is the first thing. And second thing is you should not be putting too much IOP so that can go into the anterior vitreous. Of course, you will be taking it out, but you'll make sure that it won't dislocate further. Of course, the vitreous is going to be firm in pediatric cases, but here it can go into the anterior vitreous, and of course in some cases posterior vitreous also. But by using this image, you can be more sure, you can prepare your minds, and you can change your parameters. This is one more interesting case scenarios. So we have two different cases where anterocapsular rexus has been done, and we have taken out the lens matter. Now there is a postcapsular plaque. How AIOCT can be useful in these case scenarios, right? On the left side, in the dark black images, you can see that there is a postcapsular plaque is there, of course, right? But here you can see that the postcapsular plaque is quite thick. That is first thing. Second thing is, whatever the duplicated layer is there, it is in the anterior vitreous. It is not in the bag. And probably if you want to take it out, probably it's not going to come through just bimanual aspiration, or you won't be able to do the puncture using the needle. That is the first thing. And you won't be able to do a PCCC using any intravitreal forceps because it is quite thick. It can run away. That is the thing. So probably you need to put a stab incision here, then use an intravitreal scissors and fashion it out. So if you do that one, obviously you won't be able to put the lens in the bag. Probably you need to put in the sulcus. So this is how iOCT is going to tell you that this capsule is very thick. It is very fibrotic. Probably it's not going to come through your simple needle, tomy, and intravitreal forceps, right? So on the right side, you can see that the fibrotic plaque lies in front of the capsule. You can see here on the lower image, I can see you can see that arrowhead, right? So it is actually elevating on the anti-surface of the capsule. So that's why Kokasa, what he does is like he takes the sense key and he just peels that one. He peels that one and he just rotates it, right? So you can just clean it. It's like you are like wiping the floor, right? So you can just pull it up and you can do the excess sort of thing. So that's how you can avoid any capsular damage. So there, once you take out the plaque, which you got to know through AIOCT, it is not behind the capsule, it is anterior to capsule. Once you take it out, then you can do a round PCC, then you can put the IOL in the back. So that's how iOCT helps in understanding how the plaque behaves, whether the plaque, the duplicated layer is behind the posterior capsule or anterior to posterior capsule, which otherwise you can't decipher here, right? So this is one more interesting case where the patient underwent surgery and there is a opacity here, right? Under the microscope you are able to see that, okay, how I can take it out. So, but AIOCT comes to rescue, it shows that, okay, this is a well-defined posterior capsule and it is in the Berger space, right? So Berger space has been dissected and there is a reaction here, and in that particular space there are some reactionary materials are there, right? So surgeon does a small opening here and he's tried to inject it, and you can see that after putting some viscoelastic, the space is expanding, right? So he's going to do a rexus here and he's going to take it out, right? So otherwise if you are doing just based on microscopic view, or if surgeon is naive, probably he feels that there is something on the back. So if you do OCT, it shows that just it is beneath the posterior capsule. You can take it out by doing a good PCC. So to conclude, UBM is an essential tool. It is an essential tool in pediatric cataracts. You cannot do pediatric cataract surgery without UBM. Of course you can do, but most of the times, in more than 90% of the cases, it gives some sort of details. What is the sulcus, how the sulcus is, how is the anticapsule, how is the lens, and that's why it's an essential tool in imaging pediatric cataract, where it reveals specific finding related to antechamber depth, lens, and the sulcus. In contrast, iOCT is a supportive tool. It's going to support your findings. It's going to be supportive during your surgeries. So which is going to give intralenticular details, anticapsular detail, postcapsular details, and the anterior haloid details in a micro form. It is going to be in a macro form or a larger view.